Yep, it is start the presentation at any time.
Hero. Delighted to have you with us today to talk about sustaining your fall prevention practices at your hospital. We know you've had multiple opportunities up to this day for going through other parts of the toolkit and projects that you've already been implementing to enhance your fall prevention programs. And then what we want to do is to really focus on sustaining your fall prevention practices at your hospital. So welcome each and every one of you today to this session and joining us, and hope that this will be helpful to you, because the biggest limitations that we have when we're trying to change practice and implement innovation is trying to make sure that the efforts that we're making and the practices that we're changing are really sustained, that they become part of our culture. So what you're hearing today is Pat Quigley. I'm back with you. I'm just delighted to be able to be here back with you. And I introduced myself to you before during the session, in the beginning session of orienting you to this program, that we'd like to just say a little bit is that I am with you as a rehab nurse who won't give up on falls. I'm at the Tampa VA Medical Center, and I help with patient safety programs. And you could read the rest of what's in there on the slide about me. But what we really want you to know is that I'm here to be able to help you with learning about sustainable fall prevention program. So today we're going to talk about the purpose and the challenges of sustaining fall prevention practices, who sustain these practices, the support needed to sustain these practices, measure fall rates and prevention practices, and then also other ways to help sustain your program. So make sure that you have some note paper and something to write with so that you can go ahead and take some notes, and you will be able to ask those questions if any questions you might have with your quality improvement specialist. So please do take some notes as we go forward. Your quality improvement specialist will follow up with you after this webinar to help address any questions or concerns that you might have. So sustaining practices is that you will soon be implementing these fall prevention program elements at your hospital. When you did your assessment and you identified how fully operational are program components of your fall prevention program, you found some activities that are not in place, you found some activities that are somewhat in place, and then you found some activities that are fully operational. So we're hoping that that guidance was really helpful to you to identify those activities that you're going to do that you want to be able to implement. So implementing these program components, and we also know that you will have successfully implemented this program when you've had 3 to 6 months of consistent improvement. Down to measure, you have some measurement here already in terms of time frame for actually seeing if any of those changes in practices are reliably being implemented. They become part of your culture. Colleagues, your work is still not over. It takes a lot of work, a lot of coaching and mentoring to be able to sustain practices. So your hard work will not be over, even in 6 months. So we want to make sure that you're going to continue these efforts and your new practices will continue over the long term, and that you will take the active steps needed to be able to sustain changes in practice. But talk about the challenges in sustaining practices. You know, novelty is worn off of something that you're trying to do. People slowly go back to old approaches. And this is kind of what we call drifting back. It's easy to drift back to the things that we've always done. It is not for the faint of heart to go forward. So there are needed resources that to be able to continue to help programs enhance their activities that they're doing and their sustainability, because oftentimes what you'll find is that the needed resources may no longer be available. It was there once we were really engaged in it, but no longer do we have them. The practices may become harder to perform over time, and then that results in some barriers to implementation and some resistance that you might have. And we know that staff may leave and be replaced by others over time who are doing things differently. So it's not you can can teach people things one time and hope it will be sustained. It takes a lot of work to be able to keep the staff engaged, to ensure that everybody is at the same level of performance in implementing these practices. And there's really two mechanisms to help you sustain practices when you're looking at who will help sustain these. So in the section of your toolkit, there's some really rich discussion on unit-based champions and your sustainability team. So we want you to think about these two groups of people that you need to have in place as you go forward with the great work that you're doing. So colleagues, let's first go ahead and talk about unit-based champions. Unit or staff members who are serve as fall prevention resources at the unit level are really key to helping to sustain your fall prevention practices. The unit-based champions, and you'll find this information in 6.3 of the toolkit, designed to help you be able to increase the infrastructure and capacity at the unit level, to make sure that at the unit level people have the resources that they need, that they're to help with encouraging and mentoring people, engage people at the point of care 24/7 around the clock to be able to help make changes. Unit-based champions are an emerging, effective group of people in helping to change practice. Because remember, it's not easy to change practice. So if you were to think about one of the concepts or the approaches to fall prevention, there's a whole science on innovation diffusion. How do you take new ideas and get them implemented? And these champions really came out of that whole approach to implementing new ideas. Some of you will remember unit-based champions who first were pain resource nurses, when you're going to help deal with pain issues at the point of care and how you were helping staff to really change their perceptions and their practices on pain assessment and pain management. They were probably one of the earliest roles that we had that were unit-based champions, unit-based peers. Another example of unit champions would be your skincare nurses. When skincare nurses at each unit level, some may even be familiar with back injury resource nurses. That's the innovations that we've certainly had in the VA for quite some time, the Department of Veterans Affairs. Unit-based champions are not new. But unit-based champions in the role to fall prevention this is new. You will not find anything in the literature related to fall prevention champions, unit champions. So this is a very exciting component that has been integrated into the AHRQ toolkit. Many hospitals have safe patient handling and movement champions, and that role has also accepted the responsibility for fall prevention, so they're doing both. So you think about how to be able to select people who can be your unit-based champions. You've got resources for this in this toolkit. And realizing that you're going to have the unit-based champions be able to have expert knowledge on fall prevention. So that's if you're going to expect them to sustain these fall prevention programs, they have to have some education, some clinical competencies in fall prevention. Think about having unit-based champions, but multiple ones, because if something happens to one person or they go on vacation and you don't have that person there, you've got to have more than one person to help be a unit-based champion. Just to see on the slide, if they leave, then you could let institutional memory. The unit are engaged. And what I want to do in the unit-based champions is to have people who are the early adopters, the people who really embrace change, are excited about doing some things that are new. Think about different strategies to be able to help keep them engaged, raise unit-based champions as needed, but people who, again, it's going to be more than one person, but people who really are seeing peer leaders at the unit level and are going to be able to affect some change. Simple resources that are in the toolkit, or again, it's in section 6.3 of the toolkit on the unit-based champions. This group of people, to be able to help you sustain practice, are going to be your sustainability team. And this is the role of the sustainability team. This team is going to be the group of people who are going to disseminate new information. And use some examples of how to be able to disseminate new information. Staff bulletins, posters, flyers, and bathrooms, staff education fairs, those kinds of things. But you got the information to the hands of people. That's why you want to hold meetings to be able to discuss the new information, discuss some outcomes that might be related to this new information, update materials, and update policies. The system is also going to help with keeping your staff enthusiastic about changes, building directly with your unit-based champions to help with this implementation of change and helping to keep people engaged. They're going to make sure that there's data collection and reporting that's fully integrated into your routine work processes. Now, what we're talking about here, remember in prior sessions that you've been able to attend, we need to be measuring structure and processes. So this sustainability team is also going to be keeping on top of the data that's being collected and reported. That's why I'm going to be fully engaged in this, because it will help examine how are the work processes proceeding. What are barriers and facilitators to change? How is it working? How are we getting practice to change 24/7? It's not just on the day shift. So they're going to be really engaged working with the whole team. In addition, they'll be reviewing the literature to help make sure that we're identifying some new practices that are evidence-based that we maybe need to consider and maybe trial. And they'll be taking up new challenges. Sustainability team, and this role is in 6.2 of the AHRQ Toolkit, and to be drawn from your implementation team and or unit-based champions. So as you think about who's going to be on this team with ensuring that whatever changes you're making are going to be fully operational over time, going into that 3-6 month period of time, you want for the people who are going to make a commitment over the long haul to help with evaluating the success of the program. If the implementation team should clearly assign roles to new project owners, have handoff of facts about the project if they're going to hand it off to any new owners. But this is really critical to you because many of you probably have experience on trying to implement change, and everybody's very excited about it in the beginning, and then we just kind of have as much attention on it, we don't have as much emphasis on it, and then things just kind of like fall by the wayside, and you drift back to those routine practices that we've been doing already. And that's what we want to happen here. Colleagues, we want you to be robust in implementing changes that are going to improve patient outcomes, reduce those preventable falls, related injuries, enhance your infrastructure and capacity. Support that's needed to sustain these practices, what a team can do and what the leadership can do, is all discussed in this section of the Falls Toolkit. It's also discussed in section 2 of the Fall Toolkit. And looking at starting to examine change, the awareness of the team and the change that's needed. Tool in 6A of the toolkit with key elements for how to ensure that you have a thriving sustainability team, because you want to keep this team engaged too. So what can the sustainability team do? They can make sure at the unit level that the staff are appreciating the need for the fall prevention program, that the fall prevention program is ongoing, that they understand their role in fall prevention and how that relates to the roles of other staff members. At a level, the sustainability team is essential for helping people to really appreciate the value of the fall prevention program. As you know, in many units, fall prevention is not always the number one priority. You think about this in relationship to mental health units. In mental health units, the priorities are helping to deal with behavioral issues, psychosis, whatever kinds of issues that we might have in relationship to how people are managing themselves. So fall prevention is not always a priority. And help them be able to think about what are they going to do and appreciate how at-risk people are for falling, and what do we need to do to be able to help let this rise to a level of importance that we're all going to work together on fall prevention and injury reduction. When you think about that staff, you know, there was a prior session that you had where you were going to select maybe one unit and go forward. Well, this sustainability team can help you to work with that staff and make sure that they're really engaged, they know what's going on, and again, understanding their role with the interdisciplinary team. At the unit level, it has to be the interdisciplinary team. And the sustainability team can help provide feedback on the effectiveness of the fall prevention strategy. So these are going to be the practices that you're implementing. How are we doing? How are we rolling it out? What kind of progress are we making with the cycles of change? How are we continuing to spread, knowing that we're making things, each time we implement something, it's getting better? And celebrate some success. And you want to find ways to be able to celebrate success. If they've made some changes in practices to help people to feel really good about the changes that they're making. Maybe it's a very difficult thing. We've been working as a team to identify strategies for someone who already fell in our care, and our commitment was to try and prevent a fall from occurring, a repeat fall from occurring in the next 2 to 3 days, and we were able to do that. We want to be able to celebrate success, and the sustainability team can do that because they've been helping to follow practices in your fall prevention strategies. And they can provide needed training and retraining. As we see some opportunities for helping to keep people engaged, maybe we find some opportunities where we're drilling back to practices that we've been doing rather than the innovations that we're trying to implement, and we need to do some retraining and get people back on track. And then they can track performance routinely as well. The sustainability team is essential to you in going forward. What else can they do? The sustainability team can help design systems and prompts to ensure that the care is carried out appropriately. They are doing reassessments of fall risk. They are implementing interventions to be able to reduce injury and create these prompts. They help you with designating a sufficient number of unit champions, so that we do have those resources in place. Integrate fall prevention practices into existing organizational structures and routines so that it becomes part of our culture. You want part of the culture, not something that's thought about after patients fall. We want to be able to make sure that this is what we're all thinking about and keep people safe as part of our daily work, our hourly work, our work by minutes. Monitor fall and fall prevention practices, and then you'll see the alignment here between practice and rates. If rely on your sustainability team to help you evaluate practices, then you can see if processes are changing over time, and you'll be able to know in advance, is this going to be able to help us reach our aims in reducing those preventable falls and the injuries. So the evaluation of practices over time, processes of care, is really essential in helping us to see our outcome and to be able to be achieved. What progress are we making as we reach our outcomes? The sustainability team can help report to the hospital's oversight committee the progress that we're making in relationship to practice and keeping people safe, maybe reducing risk factors so that patients haven't fallen. Reporting risk factors and risk factor reduction in this case, and that would be changes in relationship to the fall prevention practices. We resolved orthostasis. We made sure people were up and walking. People had their ambulatory aids. All those are all practices. To request needed supplies and equipment, because what we had said in the beginning is sometimes what happens and barriers to implementing change and innovation is after the excitement phase of newness is that we no longer have supplies and resources we need. So this sustainability team can help you with this. So colleagues, it does come back to what hospital leadership can do. And what hospital leadership do? They make sure that we have the funded resources that we need for the supplies, education, and training. The hospital leadership needs to be kept abreast of all the prevention efforts and the progress that's being made. And they can help promptly fill the vacancies that exist. We have issues around maybe the unit-based champions, even members of your multidisciplinary team, or staff at the unit level, and help you with support for electronic data collection. We've had sessions on data collection, but try to have resources to help with the possible burden of data collection when you can extract it electronically. And the leadership component of this was in Section 1 in assessing your hospital's readiness. But leadership makes a difference. And that's why the leadership team is going to be continuously informed by the sustainability team. They will be connected with them, be reporting to them, so that leadership is engaged. Many of what you'll find, too, as you set up your implementation teams is that you have executive sponsors on your program, and so that leadership is always engaged from the beginning, throughout the process, and evaluating the program is going and progress towards outcomes. So the section that we want to talk about, so let's move into measurement, fall rates, and the practices. Because part of what your unit-based champions will have information related to, and your sustainability team is going to help you with. During fall rates and prevention practices, they're now getting into structure and process. You know, it's getting into our outcomes. We're doing fall rates, and hopefully you're going to be measuring falls by type of fall. But if your outcomes will not change if you don't change your structure and your process, and that's one of the most important components of this toolkit, because toolkit is all about getting the team on board to help you change practice. Look at structure, look at your process. So the purpose of measurement is to help us know where are we in relationship to our structure and our processes, to our aims and our outcomes. It helps us to know, are we making progress? In addition, you have your PDSA cycle that we'll be talking about. We'll talk about some examples of process measurement, outcomes measurement, how to measure, and how to assess the data. These are all components of being able to measure how your program is working. So measuring fall rates and fall prevention practices allows you to be able to improve your fall prevention program, to know you're making progress. You have to be able to align any changes in structure or process with the goals that you're going after, reducing preventable falls. It keeps you on track. It keeps on top of how we're doing and measuring our implementation. You won't be able to stay on track. So this is really essential for you, and demonstrate the success that you are making to the people at unit level as well as to leadership. It is important to keep both groups really informed on the progress that we're making because we're reaching our aim. So you want to reinforce the desired results. So many of you are familiar with the PDSA cycle, the Plan, Do, Study, Act cycle. Well, you see this on the slide, and indeed, this is a form of implementation. And the PDSA cycle is actually grounded in a theory, and it's the theory of change. So this plan change theory, there are multiple theories of change that are available to us as a purpose of implementation. This intervention or this component of change is grounded in plan change theory. In relationship to falls, because I'm just confident that many of you are familiar with the PDSA cycle. So the PDSA cycle is an iterative process, and an interactive process that's based on scientific method, as I mentioned, a theory of plan change. It's assumed that not all information or factors are known at the outset. But it's cycles of change and evaluation that are needed to achieve a goal. And each cycle moves you closer than the previous one to the aim that you're trying to achieve. With cycle, you have improved knowledge, and you may choose to refine or alter the specific goals that you set at the outset. But each cycle, you have improved knowledge about what it takes to implement a change. So PDSA cycles are small tests of change, maybe one patient at a time, one at a time, one nurse and a patient at a time, one unit at a time. But the small tests of change that are action-oriented to be able to help you learn about barriers and facilitators to change so that you can address the barriers, you can enhance the facilitators, and we can be successful. If you have barriers, even to completing the PDSA cycle, then what happens is whatever you're trying to implement will fade away. It'll fizzle away, or you may even be dealing with some people who are resistant to change. And maybe you have experience to people who have been resistant to change. It's not easy to change practice. So the PDSA cycle really makes it much more possible for you to be able to change practice. It's grounded in plan change theory, and it's also essential in terms of implementation science, your implementation process. This is a familiar slide, I'm sure, to you. You know, repeated cycles of change. So you have an idea. You have what you think you need to do to be able to reach something. What are the steps to be able to affect change? You have an idea so that you want to trial. And hopefully through working through the toolkit and working together in your implementation team with your implementation team leader, you have some ideas. Maybe we're trying to think about how to be able to integrate injury risk into our assessment protocol. So we're going to assess, look at what injury. Maybe we're going to think about the risk of someone having a hip fracture. And what do we do to be able to prevent that hip fracture? So maybe we're going to roll out a floor mat as one of those strategies. Maybe we're going to assess risk for injury. So look about the floor mat. The floor mat is one of the strategies for reducing trauma if someone falls. So you have this idea that this is an intervention that could help us reduce the risk of injury. So take that floor mat, and we're going to use that floor mat on one patient, and we're going to put that floor mat at the bedside, and we're going to see how did that floor mat work when the patient was resting in bed on day 1. And then we're going to do a debriefing. So we have a plan. We're going to implement the floor mat on one patient at a time. We've gone ahead and done this one patient at a time. We've planned it. We've done it. Now we're going to study how did it work on day 2. How was it accepted? What barriers do we have? And after that, we're going to make some changes in the implementation and the use of the floor mat. That's going to be the plan, do, study, act is the next step. So we act on the next cycle of change, making some changes in the use of the floor mat. Maybe we found out the first time that we used it that we had some problems keeping the floor mat down all the time instead of picking it up when the patient was getting up and out of the bed, so that we had some problems with people tripping on it. We made some changes to that implementation on the next cycle of change. As you see, with each cycle of change, you have to do that debriefing after to see what were the barriers for the facilitators, because hopefully with the second cycle of change, you reduce some of the barriers that you assessed in the first cycle of change, and we make it more successful. So now have more facilitators than barriers. You have to get to the barriers and enhance the facilitators, but resolve the barriers. So for the cycles of change to continue to ascend, not descend, but to go up, to ascend as you see on this graph, that means that we're continuing to reduce barriers to implementation. We're strengthening the implementation by enhancing the facilitators so we can help achieve that result of reducing trauma if someone was to fall from the bed, for example, along to the use of floor mats. Every single cycle, as you heard, was iterative, but it's so interactive. You have to be able to learn from each and every one of them, have the staff engaged in doing these debriefings after. All of these you should be keeping notes of. So the sustainability team, your measurement team, is looking at how are we affecting changes in practice. You want to keep notes on what worked, what didn't work. That didn't work, what did we resolve them? What did we try the next time? That's implementation. If you can get through this implementation process using your PDSA cycles and keep notes related to the changes that were made with each of these cycles, then you're going to help be able to, if you will, create a toolkit yourselves on the implementation and give the next unit, because this is what we've been working on this unit, and we want the next unit to be really successful. But it's ascension. You don't cycle this graph to be showing a downward trend that things didn't work, and that's sometimes what happens. So on the slide, you have some examples. Because of colleagues, you could have multiple tests of change that are going on at your unit level. So our overall aim that we established for our unit was to lower our preventable fall rate by 40% in 7 months. So what things are we doing to be able to achieve this? Remember, when you're implementing a program, it's more than just one practice initiative. So in a fall prevention program, we're going to get our assessment protocols to be able to look at our assessment of fall risk, make sure that we're identifying actual fall risk factors. We're not just making decisions based on a score or based on a level of fall risk. We want to get to those fall risk factors. You heard about focus on the fall risk factors in Chapter 3 of the Toolkit. We are going to look at also integrating into that assessment protocol injury risk. So we're going to develop an assessment protocol that deals with fall risk factors and injury risk. And you're going to develop the templates for it. You're going to implement it one patient at a time, see how it's working, do your debriefing with the staff, all with the intent of helping to ascend and getting this integrated into practice. Develop knowledge about falls and fall-related injuries. That's going to be aligned to your assessment protocol. And then to roll that knowledge out, you're going to help people learn about that, but it's not just about learning, knowing something. You want to see if they're going to do something different related to that. So maybe you'll develop an environmental assessment. The environmental assessment the staff could use to integrate new knowledge that they gained, the risk factors that are associated if people get up from low beds or if they were to get up from chairs that are too low. It's all about reducing fall, getting ready to reduce your preventable falls, accidental falls, and anticipated physiological falls. You'll develop specific interventions for fallers. And what might interventions be? What are you implementing for people who have sensory neuropathy in their feet and they've got gait and balance problems? What interventions are you implementing for people who have already fallen in your care? So people who are fallers, these are known fallers, people who got admitted because of a fall. To develop some specific interventions for them, maybe right brain versus left brain CVAs, that you have to develop some specific interventions that are specific to your patient population. Or conduct some patient education related to this, to the fallers that had occurred on the unit and what were their root causes and why they fell. So one of these aspects that you see on this slide are going to help with looking at your entire program. Remember, your program, implementing a fall prevention program, is identifying risk, treating risk, conducting staff education, patient education, and evaluating the effectiveness of the program that's multifactorial and interdisciplinary. You should have tests of change that are going on to help you enhance your multifactorial assessment, your interdisciplinary team. It takes staff education, and it takes patient education, and measures for that. So that you have to have some process measures. So process measures, here are some examples, because you measure practice. 10% of the patients are indeed at risk for falls and fall-related injuries and have some interventions in place. So in this process measure, we had to have some structures in place to be able to identify patients who were at risk for falls and also at risk for fall-related injuries. So we've already done that. We've gone ahead and implemented some interventions. So what we want to do now is see what percent of these patients who are at risk for falls and injury actually have some interventions in place. So that means we have some practices in place. Or patients who had completed purposeful rounding, the intentional rounding. And really the most important components of purposeful rounding for fall prevention is that people are on scheduled toileting and people get to the toilet before they get pain medication. And with the risk for having an accidental fall, that they slip on, spill, or trip over tubing, that there's clutter in the room. Because always make sure that the rooms are clear of any kind of trip or risk hazards, say, with falling before we leave the room. So 1% of patients actually had this done, that we could maybe link the rounding to a reduction in those two types of preventable falls. And also decide how are you going to collect the data. Whenever you're deciding on process measures, structure or process measures, you have to decide who's going to help you collect the data. So maybe you'll do some observation, maybe you'll do some chart review. Review sometimes is limited because not everything gets documented, but you can do an awful lot with observation. observing 5 randomly selected rooms, or doing environmental rounds and doing observation but you have some data collection tools for either one of them. You have to have a data collection tool for observation. You have to have a data collection tool for your chart review. So whatever process measure that you have to develop a data collection tool. The data that's going to be collected, make sure the sustainability team is helping with that, and then deciding on how to collect the data. But colleagues, process measures answer this question. Are things that we think will lead to the improvement in the outcome. So process measures have to be aligned to the interventions that were implemented that are then always directly related to your aim statements, reducing preventable falls and fall-related injuries. Remembering that with preventable falls, you have accidental falls and anticipated physiological falls, and the interventions to protect people from an accidental fall are all related to a safe environment, whereas interventions to reduce anticipated physiological falls are all about that multifactorial assessment and that interdisciplinary team. So you get data that's going to be collected for each one of them are going to be different. But they're outcomes. Your outcomes are going to be your fall incident rate, and that would be new falls that occur, and that would be accidental falls, anticipated physiological falls. We're going to reduction of your preventable falls, anticipated physiological falls, or prevalence rate. That's going to be your rate over time in a quarter. We're looking at your fall rate. So those are examples of your fall rates that you're going to be measuring in terms of outcomes. Outcome measures that you will have. We probably should always talk about fall injury and collecting fall injury data. So you reduce the severity of injury because that's part of our commitment as well in going forward with implementing this program. So to measure, you have to decide on who's going to measure the fall rates, who will be collecting this data, who will measure fall prevention practices, who's going to keep on top of the fall prevention practices that are going on. This is one of the roles that you could really engage your unit-based champions on and help them to be able to keep track. How are we doing in rolling these out? Because that's part of their role, the unit-based champions, is to be engaged in the prevention practices that we're implementing. How well are we doing? Receive the data, and what are we going to do with the data? And use that data back into the hands of the staff in the unit, because the staff need to know how are we doing with practice, how are we doing with process. Because it's the practices that we implement every day with patients. Patients don't fall every single day. What are we doing to be able to change practice? And that routine workflow. So the routine workflow for our data collection has to be established. And then on how to assess the data. Does what changes in data represent a real success or concern for your hospital? Maybe we did successfully reduce the repeat fall from occurring with a very difficult patient, a patient who has dementia on a medical surgical unit, and we were able to reduce that. We had a patient who fell twice in 3 days. For the last 3 days, we haven't had a fall. What were the changes that we made? What represents real success? It wasn't just that the patient was sedated. Maybe it was the patient had more frequent rounding. So that's what you want to decide on, what data is going to represent real success. Or if there's a concern that maybe we had seen that we had more falls that were occurring on a cardiac unit, and we realized that patients weren't being assessed for orthostasis. You want to go back. If you start seeing the fall rates increase, or not to where we thought we should be, that we need to find out what's going on. Or how staff are being engaged in relationship to the changes that are being made. And they'll keep you from reacting to temporary fluctuations. Each one of the, I cannot emphasize enough how important every PDSA cycle is in keeping track of how the success of getting something new implemented and the barriers. We want to be able to eliminate those barriers. And track, you can be in a position of reinforcing desired results because you want to celebrate success. People work hard every day to keep patients safe in our care. We want to find ways to be able to celebrate the small tests of change that are being successful, and this will help you in other ways for sustaining your program. So ways to be able to build in success, because when you work in patient safety, says fall prevention. It's always so easy that we just focus on the falls that we're not keeping track and celebrate all those patients who were so at risk that they did not fall in our care because we did indeed keep them safe. We made some changes in practice. So recognize the success in your fall prevention program. It allows you to generate and maintain that excitement about changes that are being done, and people for small changes. But help it be regular, such as gift certificates. People like food, whether it's pizza parties or whatever, plaques. Sometimes people have trophies. That you will see trophies that are mobile trophies that celebrate help one unit be able to recognize some really innovative things that they were able to sustain over time, or things that they did that kept a really difficult patient safe from falling while they were in our care. That was innovative. So some ways to be able to celebrate success level. You want to find small success early, and that's what you can do with the PDSA cycle, so that you can reward staff for the first time that they try something, maybe integrate injury risk into their assessment protocol, they used a new assessment form correctly, or conducted an environmental assessment on their patients. Something that they did and celebrated successful, and then raising the bar and reward people for not having any preventable falls in the last 3 months, and celebrate that and recognize them across units. Unit for the greatest decrease in fall incidents, new patients who came in that had a fall, that we were able to prevent this from occurring. And posting the results for each unit and for the hospital overall, so that everybody can share in the success. At the individual level, maybe you recognize, as you see here, the Champion Cup, for people who really made the extra effort, that spent special time with patients and helping patients to know why they're at risk for falls, not that they're just at risk, and are we doing what we're doing, and what are the interventions that we're putting in place to keep them safe. Recognize one staff member for a quarter who actually successfully implemented a fall prevention program or an injury reduction program, that they did extra effort to make sure that patients who came in that already had hip fractures had those floor mats down. So you staff from a variety of disciplines and help them all to be able to celebrate success. Other ways of sustaining your program. You can work with the hospital's quality improvement team to coordinate your sustainability programs with others, and really make sure that that the organization is involved. So it's not just something that's being done at the unit level. You want to address staff turnover, because when you have staff turnover, it does require more training that needs to be done and integrating the new staff into your fall prevention program. There's a learning people up to snuff, if you will, up to the standard of practice that you want to have, and to continue to be engaged in excelling the advances in your program. And then each month to be able to address any kind of root causes that are going on, because you want to stay on top of why people are falling. Because you don't prevent all falls. So when falls occur, you do want to keep track of why are people falling. What are the immediate causes of falls we need to address to be able to link interventions to why people are falling and prevent these people from falling again, our patients. And then engaging the hospital falls committee, your co-chairs, your managers, or clinical staff that should be attending and looking at why are people falling in our care. But you need to celebrate success and to measure your fall rates, by preventable falls, measure your fall prevention practices, your injury reduction strategies, and then reducing your severity of injury. So that program elements are really fully sustained, is to become part of your culture. You can no longer have to follow up to see if the 85-year-old who came into your care, who you know that's their #1 cause of death is a fall, that something's being done special for that patient. Or the patient already fell in your care because something happened, that their blood pressure dropped, they had orthostasis, that their orthostasis got indeed addressed and resolved. And now done for everybody, that we're assessing everyone for orthostasis on admission. So something really becomes sustained is when it's part of your culture, it's part of your daily practice. People don't have to think about it anymore. You've actually changed your practice. So I talked about the challenges of sustaining a fall prevention program. Who will sustain these practices? The support needed to be able to sustain these practices. Fall rates by type of fall in your fall prevention practices. And we also included injury reduction. Remember that even minor injuries can be grave in older people. And old people don't even have to have a head strike to have an injury. You know, they can still have a bleed that occurs. So, you know, always remember the severity of injury component, and the minor injuries can be grave. It's not just the most serious of injuries. And then we've also talked about other ways to be able to sustain your program. So we hope this has been helpful to you. You've successfully attended all 6 of the sessions. We hope that over this period of time that if you did have any questions, you went ahead and wrote those questions down. If you have any concerns, that you've gone ahead and kept track of those concerns as well, because we want you to refer those to your quality improvement specialist. You all have been great listeners. Cannot thank you enough for all of your attention. And to the best of success as you go forward, and much engagement as you make changes in enhancing your program. You have all kinds of resources that are available to you. Absolutely, in the Falls Toolkit, you've got the website here. And then there's that business case tool that was in item number 1D to look at the return on investment, how we go forward in measuring success. And then the tool, which was 6A, which was a sustainability tool. So great, everybody, and we wish you continued great work. Thank you so much. Bye-bye now.